systemic lupus erythematosus. I'll be discussing first this vasculites in SLE. Vasculites in SLE, it's no single fixed vasculitis pattern that we see in SLE. So there is no single fixed pattern, but the most common form is this leukocytoclastic vasculitis. It affects small vessels most commonly. So this is the most common form of vasculitic pattern that we see. There can be other patterns as well, and this pattern affects small vessels most common, and sometimes medium vessels are also involved. So what is this LCV? It's caused by this immune complex deposition. There is this neutrophilic infiltration, and subsequently there is destruction of vessel walls. So on histology there is a classic triad. One is fibrinoid necrosis of vessel wall. Second is fragmented neutrophil nuclei, that's also called nuclear dust. That is why it's called as leukocytoplasia. So this is because of this one unique histological feature, that is fragmented neutrophil nuclei. This is the second histological feature among the triad. First one was fibrinoid necrosis of vessel wall, and third is perivascular inflammation. So there is this is a vessel, and there is this perivascular inflammation. This is the classic triad, histological triad of this LCV, leukocytoclastic vasculitis. And clinical features that we know: palpable purpura, that is non-blanching spots mostly on lower limbs, urticarial vasculitis, livedo reticularis, ulcers, digital ischemia. I will be discussing few topics about the SLE. So we know that there is this lupus nephritis. What is this lupus nephritis? You should be knowing that kidney disease is one of the most serious complications in SLE. Its pathogenesis is immune complexes, that is this anti-DNA and anti-nucleosome deposits in glomeruli, and there is this complement activation that leads to inflammation, eventually ending up in proteinuria, hematuria, renal failure. Musculoskeletal symptoms can be, which are the most common, that's 95%. So 95% of the symptoms are musculoskeletal. There can be arthralgia, myalgias, polyarthritis, hand deformities, myocytes, ischemic necrosis of bone, that's also seen there in 15% of the cases. Cutaneous manifestations, for example, photosensitivity, malar rash, oral ulcers, alopecia, discoid rash, vasculitic rash. Other examples can be urticaria, subacute cutaneous lupus. Renal manifestations: proteinuria greater than or equal to 500 mg per 24 hours, cellular casts, proteinuria greater than or equal to 500 mg per 24 hours, nephrotic syndrome, end stage renal disease. So I mentioned cellular casts, that is seen in 30 to 60% of the patients. So what is actually a cast? Casts are these cylindrical structures. They are formed in renal tubules. They are made up of this protein that's called uromodulin, aka this tam horsefall protein, THP. This protein is secreted by tubular cells, and when cells or proteins get trapped in this gel, a cast is formed. So when this uromodulin plus cells or uromodulin plus proteins, they form this cellular cast or protein cast, and thus casts are footprints of what's happening inside the nephron. So we know that there are many types of casts: hyaline cast, Hyaline cast content is just TAM horsepower protein. So when this is the only content THP, then the casts formed are this hyaline casts. You see this Euro model in multiplied by n times and formed into this cylindrical shape is called hyaline cast. Second is RBC cast, that is made of RBC cells. Similarly, WBC cast, granular casts. Granular casts are simply degenerated cellular material. And epithelial cell casts are renal tubular epithelial cell casts. Waxy casts, they are broad and dense. Fatty casts, they are lipid laden macrophages. Maltese cross interpolarized light. So what is typical of SLE? In SLE nephritis, the hallmark urinary finding is RBC casts. They reflect glomerular inflammation and bleeding. So this is the hallmark of SLE nephritis. Sometimes WBC casts too, but without infection. It's due to sterile inflammation. So proteinuria and cellular casts are red flags in lupus. Means real glomerular involvement, not just benign proteinuria. So when we say cellular cast in SLE, we usually mean this RBC cast. So this is what is commonly seen, this RBC casts, as I mentioned, in clinical manifestations of SLE. So why is this important? And this why is this cast important? So you see, spotting RBC cast in urinary microscopy is strong evidence of this what's called as lupus nephritis. That's especially class 3 or class 4. It helps differentiate from other proteinuria causes like orthostatic proteinuria or infections. Now, why does this cast form? You see, there is this immune complex deposition within the glomeruli that causes RBC leak, and eventually it mixes up with uromodelin, aka TAM horsefall protein, resulting in formation of RBC cast, and that appears in urine. So in one line I will say the cellular cast typical of SLE nephritis is the RBC cast, that's indicating active glomerulonephritis. As I mentioned, these RBC casts are typical of class 3 or 4 lupus nephritis. So why is that? You see, class 1 to 2, these lesions are only mesangial. So lesions are only mesangial. So in this case, capillary wall is intact. So there is no major RBC leakage into tubules, no RBC cast, only mild proteinuria hematuria you will see. So when you will do routine urine examination, you will see only mild proteinuria or hematuria, because there is no capillary wall involvement. Capillary wall is intact here. But in class 3 or 4, what you usually see is these are proliferative forms with immune complex deposition. So deposition is seen. So there is immune complex deposition, especially in the subendothelial location, and that leads to endocapillary inflammation and necrosis, crescent formation, rupture of this GBM, and eventually RBC leak into Bowman's space, and they pass into tubules, trap in TAM horsefall protein, and eventually leading into RBC cast. This is why RBC casts are strongly associated with active proliferative glomerulonephritis, lupus nephritis. These are proliferative forms. So and class 5, that means why not 5? 5 is membranous form. There are subepithelial deposits. And that leads to nephrotic syndrome. So there is no direct RBC leakage. Instead, what you will see, Fatty casts that are arranged in the form of Maltese cross appearance. They are more typical in case of class 5 membranous lupus nephritis. So in nutshell, class 1 to 2 lupus nephritis, that's mild, there will be no RBC cast. Class 3 to 4 lupus nephritis is proliferative and severe. Where is you will see these RBC casts. Class 5 lupus nephritis is, you will that routine urine examination will be nephrotic and there will be fatty casts. Whereas class 6 lupus nephritis, that's burnt out disease, and what you can see is waxy casts. So RBC cast is marker of active proliferative lupus nephritis 3 and 4, not 1 2. Now musculoskeletal manifestations, as I told you, intermittent symmetric polyarthritis you will see, and bilateral this small joint upper limb predominant non-deforming non-erosive joints you will see. Although erosions and deformities are rare, but we usually see these deformities or erosions in rheumatoid arthritis, but when this is seen in conjunction with RA, this condition of SLE, then it's termed as lupus. In this condition, erosions and deformities are seen. Common things that we already know, I'll fast forward that. Acute cutaneous manifestation is photosensitive butterfly malar rash. Chronic manifestation is discoid lupus erythematosus. Subacute form is psoriform lesions, which are annular type of lesions, and there can be small oral nasal ulcerations as well. Renal involvement is the leading cause of mortality in the first decade, along with infections, and renal manifestations are seen in 30 to 50% of patients. So these are the renal manifestations. And renal manifestations, most commonly what you see is proteinuria greater or equal to 500 milligrams per 24 hours, and cellular cast, that's RBC casts, you will see in 30 to 60% of the patients. Nephrotic syndrome can be seen in 25% of the patients. ESRD in 5 to 10% of the cases. Now we know the classification. Class 1 is minimal mesangial lupus nephritis, then class 2 is mesangial proliferative, class 3 is focal lupus, class 4 is diffuse lupus nephritis, class 5 is this membranous lupus nephritis, and class 6 is advanced sclerotic lupus nephritis. So what is the neurological criteria? Neurological symptoms you can see, one is this inflammatory, another is vaso-occlusive. For example, cerebrovascular accidents, cardiovascular this conditions or inflammatory conditions that you will see is, one is cognitive dysfunction, second is headache, seizures, and psychosis or myelopathy. And vascular conditions, these are the neurological conditions. So this is A, neurological condition, B, vascular conditions. Thrown by that is related to APLA, antiphospholipid antibodies. All the vascular complications can be related to vasculitis. Emboli can be seen due to limb and sac endocarditis, and there can be accelerated atherosclerosis. You will see in old age men hypertensive, dyslipidemia, diabetic steroid intake. Hematological manifestation, anemia most common, ormostic normochromic, leukopenia and lymphopenia, thrombocytopenia you can see, and GI symptoms can be autoimmune peritonitis or mesenteric vasculitis, also transaminitis, vomiting, diarrhea common during flare. Complications can be perforation, ischemia, bleeding. Ocular manifestations, Sjogren, dry eye. Concerning features can be, one is this retinal vasculitis, and optic neurites. Steroid related can be cataract or glaucoma. Diagnosis, we know that as per SLIC criteria, we have any 4 criteria, but at least 1 clinical and 1 immunological criteria if met, then it's SLE. But exception are renal biopsy, that is if suggestive of lupus nephritis plus any SLE antibody, then it is SLE. And it SLIC criteria sensitivity is 84%, but it's highly specific, that is 97% specificity. So renal biopsy suggestive of any lupus nephritis plus any SLE antibody, then this is SLIC criteria gets fulfilled here. So any SLE or SLE lupus nephritis plus any antibody of lupus, and second is any 4 criteria plus one should be at least clinical and 1 immunological. So what are the clinical manifestations? So I mentioned 1 clinical, 1 immunological. So clinical manifestations and immunological manifestations I'll be discussing. Clinical can be in the form of skin manifestations can be acute or chronic, as already described. Acute, subacute, cutaneous lupus erythematosus, that can be photosensitive malar, maculopapular bullous. In chronic cutaneous lupus erythematosus, there can be discoid lupus or paniculitis or lichen planus or hypertrophic verrucous or chilblains. And second can be patient has ulcers, oral or nasal ulcers. Third can be alopecia, but that should be non-scarring alopecia. Fourth can be synovitis, so joints are involved, so synovitis in greater or equal to 2 joints. And fifth can be serosites, means pleurisy pericarditis, if these things are seen. Sixth can be renal manifestations, for example if protein by creatinine ratio is greater or equal to 0.5 or RBC casts are seen, or biopsy as we say lupus nephritis. Neurological manifestations, as we know, seizures. So neurological manifestations can be seizures, psychosis, even mononeuritis or myelitis or peripheral or cranial neuropathies or acute confusional state. Eighth can be if patient has, so we have to do CBC. Eighth manifestation you will see on CBC, although it is classified under clinical criteria. So one is this leukopenia, you have count of less than 4000 per microliter, or lymphopenia, that is less than 1000 per microliter, or thrombocytopenia, that's below 1 lakh. So you see TLC, platelets is described here, and thrombocytes, sorry, lymphopenia, sorry. So lymphopenia, this is lymphocytes, thrombocytes is this part. But in immunological manifestations, we have ANA that should be greater than reference range. So first is ANA, and another is anti-double stranded DNA. It should be greater than the reference range if done by ELISA. So if by ELISA, then it should be greater than 2 times reference range. So what it means, I will first explain this topic, what it means, then I will dwell into the other immunological manifestations. You see, NDDS DNA that are a hallmark test for SLE, they can be measured by different lab techniques. One is this FARR, or radio immunoassay, and it's very specific. Another is Crithidia, Lucilia immunofluorescence test, also called as CLIFT. Crithidia lucilia immunofluorescence test, and this is also very specific. But what happens with ELISA? ELISA is very sensitive. ELISA is very sensitive, but less specific. So if it is very sensitive and less specific, then it will be having more false positive tests. And so why is that? Because there is non-specific binding and cross-reactivities. That's why we know slick criteria requires stricter cutoffs to call it truly positive. That's why if the lab uses ELISA, results must be at least 2 times above the reference cutoff. But if the lab uses this, let's call it this for radiomanaceae or Crithidia, then even a simple positivity above reference range is enough because it's very specific. But this is less specific compared to the other two. So to avoid labeling borderline or weak positives as SLE and to ensure specificity of the diagnosis, slick classification criteria are designed to avoid over-diagnosis. That's why this 2 times upper limit cutoff for ELISA method has been introduced. So what is this method of detection? That is ELISA, and it detects antibody binding to synthetic dsDNA coded on a plate. Report as units or ODs, that's optical density units or optical densities, and it requires greater or equal to 2 times cutoff for SLE classification. And so anti-dsDNA antibody positivity only counts for SLE classification if it is significantly above background. If the lab method is ELISA, the value must be at least 2 times higher than the normal reference cutoff to avoid this is only done to avoid false positives. Now continuing further, we have other antibody, that's anti-Smith antibody, and we can have anti-phospholipid apply antibodies, any of be it lupus anticoagulant or this anticardiolipin or anti-beta 2 glycoproteins. And there is low serum complement level C3, be it C4 or CH50, and positive direct Combs test. So these are the immunological tests: ANA, anti-dsDNA, anti-Smith apply antibodies, low complement levels, or positive Combs test. So at if 4 criteria are met, among them one should be this clinical, and at least one should be immunological. After that, the rest of the 2, it doesn't depend. These 2 can be from this clinical, or 2 can be from this immunological criteria. We will say patient is diagnosed as having SLE. Now for instance, I saw one patient. He had a pedal edema, and he had this malar rash, and pedal rash. I did routine urine examination, and proteinuria was around 700 milligrams. You see, it was 700 milligrams, and there was this malar rash. So at least clinical criteria 2 were present, and I did ANA by ELISA. So it came out to be more than 2 times the upper limit of reference range, and I labeled it as positive. So this patient is case of SLE. So there are certain misconceptions that I will like to explain. You see, ANA, what is this ANA by HEP2 that we usually send this investigation with? ANA by HEP2 is it is the gold standard screening method, and it is done via this indirect immunofluorescence assay. But ELISA, this is specific confirmatory test for defined autoantibodies, and but although both complement each other, but ANA diagnosis should start with indirect immunofluorescence. So ideal method, that is a screening test of ANA, should be by indirect immunofluorescence on HEP2 cells, and this is the gold standard. Whereas confirmatory or specific antibody testing, be it ELISA or line immunoblot, it is done for this anti-dsDNA or anti-Smith or SSA or SSB, etc. Why not rely only on ELISA? You see, ELISA may miss important antibodies, and there can be false negatives in this. Whereas indirect immunofluorescence, you should be knowing that screening test should be the one you should have the very high sensitivity, whereas confirmatory test should be the one which should have higher specificity. So indirect immunofluorescence is the one that is more sensitive, especially for unusual patterns like nucleolar, that is seen in systemic sclerosis. That's why indirect immunofluorescence brings this in the positive tests. ELISA will miss definitely this test. ELISA will miss this nucleolar pattern, but indirect immunofluorescence brings this in. And many guidelines, be it ACR, EULAR, SLIC, recommend first line ANA have to by indirect immunofluorescence. Then confirm specific antibodies, that is double stranded DNA, Smith SSA, SSB by ELISA or immunoblot. So what we do in indirect immunofluorescence? We take what is the process? We take patient serum and we incubate on this Hep2 cell substrate. So we incubate this on Hep2 cell substrate, and what happens then? ANA, if present, it binds to nuclear or cytoplasmic antigens, and a fluorescent anti-human immunoglobulin antibody, that is secondary antibody, is added, and that binds with patient's ANA if ANA was present. And then under a fluorescence microscope, the lab sees this fluorescence plus pattern. This is called as indirect because the detection is not direct labeling of the patient's antibody. Instead, a secondary fluorescent antibody is used to visualize binding. Its advantages. The advantages are it's highly sensitive and provides patterns, be it, for example, homogeneous pattern, speckled, nucleolar, and centromere that guide towards specific disease or antibodies. But disadvantages are it needs trained personnel, some subjectivity in reading titers and patterns is there, and also it's more time consuming than ELISA. Now, what are the markers of disease activity? One is worsen this high titers of anti-double stranded DNA. Another is low C3. Third is worsening anemia. Fourth is increasing proteinuria. So now what is the algorithm for diagnosing SLE? How to run it in real life? So you will see like this. Step 0 is you suspect SLE when you see a compatible cluster. I mean to say, for instance, a patient has photosensitive rash or malar rash, or oral or nasal ulcers, or non-erosive but this inflammatory arthritis, or serositis you see, or nephritis, so in the form of proteinuria, RBC casts, or cytopenias if you see, or neurofeatures or Raynaud's. And also if there is history of this antiphospholipid related syndrome related this history, miscarriages, etc. So first test that you are going to do is ANA by indirect immunofluorescence, but on Hep2. That is the screening test. It has got higher sensitivity, and you will also do baseline, so to see CBC, and this you will check platelets and also lymphocytes and also leukopenia, and also you will do routine urine examination to see for this cellular casts, that is RBC cast or proteinuria, and also you can see protein by creatinine ratio, and you will also see creatinine and also LFTs. You will see if high suspicion, then you can add complement levels C3, C4. These are the this is the second step. It is step 1. Now you will this was step 0. This when you suspect, when patient has symptom cluster or sign cluster, then step 1. Now comes the step 2. Step 2 is you will interpret ANA. If ANA is negative and everything else looks normal, then SLE is unlikely. Then you have to look for other causes. But if ANA is negative, but there is strong clinical suspicion, so clinical suspicion is very high, strong, then you have to repeat this ANA for once, preferably at a different lab using indirect immunofluorescence, and send also ENA panel, that is Rho La antibodies or RNP or Smith and NT, this double stranded DNA. You have to send these. And why is that? Because there are almost 5% of ANA negative SLE patients. So you have to look out for those cases. But if ANA is positive, then you have to proceed to classification. So at step 3, what you will do is you will apply classification criteria. So there are two criteria. I have only discussed one, that is 2012 SLIC criteria. I will mention the another one, that is 2019 Euler criteria or ACR criteria. That is this is the modern or point based criteria. So this is to be used. I will explain in another video. So this 2019 criteria, you will apply these classification criteria, although one of these you can apply, and let's explain this 2019 Euler criteria. So as per this, the entry requirement is ANA of greater or equal to 1:80 by indirect immunofluorescence is the entry criteria. Then you will add weighted items greater or equal to 10 points with greater or equal to 1 clinical item. Then you will classify as SLE. And heaviest weights that are carried are, one is this renal biopsy class 3 or class 4 that carries a weight of 10, also 2 or 5 that carry weight of 8, anti-double stranded DNA this that carry weight of or anti-Smith that carry weight of this 6, and low C3 C4 carry 3 to 4, also fever, cytopenias, mucocutaneous symptoms, serocytes, arthritis, etc. 2012 is also still used now, and we know greater or equal to 4 criteria with one at least from clinical and one at least from immunological, or another way around is biopsy proven lupus nephritis with ANA or anti-double stranded DNA. So after this criteria, what will be your step 4? Step 4 is you will decide your label. So if it meets criteria, then it's SLE. Then you have to assess stage severity, and subsequently you have to treat that condition. So if it doesn't meet any criteria, so ANA was positive and symptoms were there, but it doesn't meet this any criteria, but it's close. So this can be a case of possible or incomplete lupus. You have to monitor this patient closely, and you can protect this patient with hydroxychloroquine if appropriate, and manage organ problems as they arise. So clinical pearls are you always screen urine, you see protein or RBC casts can be the earliest objective clue, and ANA by indirect immunofluorescence is the preferred screening method. ELISA alone can miss patterns, and rising anti-DS DNA with falling C3 C4 often tracks renal flares. So if the anti-DS DNA titers are rising, this is rising, and C3 C4 levels are falling, so this could mark renal flare. And in seronegative but typical cases, you have to recheck with indirect immunofluorescence in this ENA panel, and you also have to think of mixed connective tissue disease and Sjogren's and drug-induced lupus. Then you have to, as I told you, you have to measure disease severity. So you have to measure here disease severity. So how will we proceed? That is measuring disease severity. You need a score to choose intensity of the therapy and to track treat to target. So what do I mean by that? You see, we have scores. One is simple and global score, that is SLEDAI, SLEDAI 2K. It's very simple and global severity assessment score and a scale, and in this there are 24 items belonging to CNS, renal, serocytes, arthritis, mucocutaneous, hematological, labs, etc. So cutoff commonly used are 0 means inactive, and 1 to 5 is mild, and 6 to 10 is moderate, and 11 to 19 is high, and greater or equal to 20 is equal to very high. So if there is greater or equal to 3, then you will classify. So greater or equal to 3 SLEDAI, SLEDAI disease activity, SLE disease activity index I will call this, and if it's greater than 3, then this is active disease. This is active disease. And there's a term called this LLDSDAS, that's called lupus, low disease activity state. That is the tree to target anchor. So it should meet all of the following. So all of the following should be present. So one is SLEDAI 2K less or equal to 4, and there should be no new features versus last visit. Second is physician global assessment, it should be less or equal to 1/3. Third is this prednisolone, it should be 7.5 mg per day requirement or equivalent of that dose. Fourth thing should be patient should be on well tolerated stable antimalarials, and plus minus immunosuppressants. So what was the aim, what was the tree to target anchor? It is this. So aim to keep patients in LLDAS, that is lupus low disease activity state, or what we call as remission, and minimize steroid exposure. Also another severity scoring index was BILAG, BILAG 2004. That's organ by organ. It grades activity per system. A is severe, B is moderate, C is mild, D is inactive, E is never active. So it maps directly to treatment intensity. That's A needs higher intensity therapy, B needs escalation, and so how we classify severity for treatment? Mild, for instance, we know mild, moderate, severe. We have to classify for symptoms. Then patient will have SLEDAI of less or equal to, I mean to say, 5, or no BILAG A or B. There should be no BILAG A or B. Symptoms will be mucocutaneous or musculoskeletal only. But in moderate, SLEDAI 2K will be 6 to 10, or any BILAG B, or any BILAG B, that is moderate. Also in that we can see serocytes, moderate cytopenias, and moderate skin joint involvement. Then comes severe, so severe or organ threatening, that is nephritis, lupus nephritis grade 3 or 4, or nephrotic 5, or neuro SLE, severe hemolysis, thrombocytopenia, alveolar hemorrhage, myocarditis, or SLEDAI score of greater or equal to 11. So less than 5, 6 to 10, and greater than or equal to 11. or any bilag A. This is how we classify severity for treatment. So this tree to target what to give by severity. Everyone unless contraindicated patient should receive hydroxychloroquine. The dose is 200 to 400 milligrams per day. Maximum you can give is 5 mg per kg. Ideal body weight baseline and annual eye screening after 5 years is to be done. And for mild disease, that is mucocutaneous or musculoskeletal symptoms, so what you offer is HCQ plus minus NSAIDs. And you can also add low dose prednisolone, that is less than 7.5 milligrams per day, short term only. And you can also give steroid sparing drugs like methotrexate or azathioprine or topical or intralesional steroids. Whereas for moderate disease, that is SLEDAI score of 6 to 10 or any bilag B. So this is moderate, this SLEDAI score of 6 to 10 or any bilag B. Then you can offer prednisolone or prednisolone. Prednisone you will give around, so prednisone you will give around 0.3 to 0.5 milligrams per kg per day with rapid taper. And you can add azathioprine or mycophenolate or methotrexate. And biological options for persistent activity, we can add belimumab, that's an add-on therapy, or anifrolumab. For severe organ threatening, then you have to give pulse therapy or methylprednisolone 500 to 1000 milligrams IV daily for 1 to 3. Then you have to taper this on oral steroids. And note that this if patient is having lupus nephritis, for example 3 or 4, then this is severe disease activity. Then you have to go for induction first. So you will do induction with mycophenolate mofetil 2 to 3 grams per day, or you can also give IV cyclophosphamide, and this is to be given with Euro-Lupus regimen. As per Euro-Lupus regimen, this is to be given as 500 milligrams. And you can also do add-on, for example belimumab, that is for induction and maintenance, and voclosporin with mycophenolate mofetil, and that improves renal responses in many patients. So we were doing induction with mycophenolate mofetil or IV cyclophosphamide, but we can add in the induction phase this drug called belimumab, and also we can add this voclosporin, that can be added with mycophenolate mofetil. And also note that for this neuro SLE, pulmonary hemorrhages, severe hematological SLE, high dose steroids plus cyclophos, or also we can give rituximab for refractory plasma exchange in selected life-threatening scenarios. So the patient has these symptoms, that is neuro SLE or pulmonary hemorrhages or severe hematological SLE. You have to give high dose steroids, so you have to increase the dose of steroids, plus you can give cyclophosphamide. And for if their disease is refractory, then you can treat with rituximab. And in selected life-threatening scenarios, for example TTP overlap or catastrophic Apla syndrome, then you can do plasma exchange. So you have to always plan to wean steroids quickly to less or equal to 7.5 milligrams per day and maintain this remission or LLDAS state. Safety pearls are you have to add this prophylaxis, pneumocystis jirovecii pneumonia prophylaxis if high dose steroids with cyclophos or mycophenolate mofetil is to be given, and gastric and bone prophylaxis is to be done, and you have to screen for TB and hepatitis before initiation of biologicals. So to summarize, A&E by indirect immunofluorescence on Hep2 is a screening test. ELISA alone can miss patterns, and NTTS DNA, if it's increasing plus low C3 C4, it can track renal activity. And RBC cast means proliferative lupus nephritis. Direct Coombs positivity is an slick immunological criterion even without hemolysis. I'll explain this. And another pearl is you have to avoid long-term steroids. You have to target LLDAS or remission. And every this 5 milligram per day of prednisone raises long-term damage risk. And belimumab helps reduces flares and steroid dose, be it systemic or renal. So belimumab is the new update. Belimumab and voclosporin also. Mumab, it reduces these flares and reduces dose of steroids. And anifrolumab is to be given for moderate to severe non-renal SLE with inadequate response to standard therapy. So this drug, anifrolumab, it is to be given for non-renal SLE but for moderate to severe, that is SLEDAI score of 6 to 10 and greater or equal to 11, or any this bilag any bilag B or any bilag A with appropriate symptom complex. So this is to be given in patients with non-renal SLE but moderate to severe, that is SLEDAI 6 to 10 or any bilag B, or SLEDAI greater or equal to 11 or any bilag A, which is refractory to standard treatment. Then you have to add this anifrolumab. Then there is another drug, voclosporin. Voclosporin is to be given for active lupus nephritis with mycophenolate mofetil. So with mycophenolate mofetil and steroids, this has to be used in active lupus nephritis, and renal remission rates improved versus mycophenolate mofetil alone. So when you give MMF alone versus MMF plus voclosporin for induction or maintenance, and in case of active renal renal SLE, then rates of remission improved with this. So these are improved remission rates although compared to giving mycophenolate mofetil alone. Now I'll give a short summary about this, why new criteria were made. You see, old ACR 1997 and SLIC 2012 criteria had issues with sensitivity versus specificity. Then this 2019 Euler or 2019 ACR criteria aimed to combine sensitivity of SLIC and specificity of ACR. They are used for classification, be it research and clinical trial entry, not for diagnosis, which is clinical. So step 1 entry criterion as per 2019 Euler criteria, as already mentioned, was ANA positivity of greater or equal to 1:80 on Hep2 cell lines, but with method of indirect immunofluorescence assay is mandatory as the entry criterion. If ANA is negative, patient cannot be classified as SLE even if they had other features. Why? Because ANA is present in almost 98% of SLE, although there can be some patients who have ANA negative but have symptom complex. So you have to reassess from time to time such patients if you have strong suspicion that they have SLE. So I mentioned weighted criteria. This after ANA positivity, you check 7 clinical domains. So you check 7 clinical domains, plus you check 3 immunological domains, and each item has a weight of 2 to 10 points based on its strength of association with SLE. The domains I'll mention only the highest weighted items in each domain counts. You see, the patient has constitutional, then fever carries the fever has the highest point, 2 points. So in any particular domain, if patient has 3 or 4 uh, items, then you will consider only the highest weighted item in each domain. And if patient has for example, hematological is one domain, hematological, there can be leukopenia, thrombocytopenia, or autoimmune hemolysis. You see, leukopenia has 3 points, thrombocytopenia has 4, autoimmune hemolysis has 4. Similarly, there are other domains like neuropsychiatric, mucocutaneous, and serosal, and musculoskeletal, and renal. In renal, we have proteinuria greater than 500 milligrams per day, or class 2 or 4 lupus nephritis, or class 3 or 4 lupus nephritis. And then immunological domain, we have antiphospholipid antibodies that carries point of 2, and we have low C3, low C4, either one of two. If patient has either low C3 or low C4, then 3 points, or if both are low, then 4 points. And anti-double stranded DNA or anti-Smith antibody carries point of 6. So you add up the highest score from each domain. Then if the cutoff becomes greater or equal to 10 points, then you classify as patient having SLE. But at least one clinical criteria, not just immunology, must be present. So at least one clinical criteria has to be present. For instance, I will give an example. If a patient has ANA positive, that's entry criteria met, and malar rash, and patient has arthritis, patient has DS DNA, then if we can combine these, so entry criteria has been met. Now from the 2019 Euler criteria, if I will assess domains and the points, malar rash will be having 6 points, and this arthritis will be having 6 points, and this dsDNA will be having 6 points. So combining, this is total of 18, but we require only 10. So this patient is having SLE. And another example I can mention, one is patient having ANA positive plus patient has decreased platelet count, and there is so thrombocytopenia, and it has got 4 points. Patient has both C3 C4 low, so it has got 4 points. Patient has apply antibodies, so it has got 2 points. So total becomes 10. So this is SLE. But if a patient has ANA positive with no clinical symptoms, but you detected patient has anti-double stranded DNA, then this is not SLE, because there is no clinical feature. So entry ANA is essential, don't forget, and highest weight items in every domain is to be taken. And also this Euler 2019, it helps avoid overdiagnosis when only serology is positive. So you have to take clinical criteria in as well. So in clinical practice, if patient has ANA positive, double stranded DNA positive, nephrotic proteinuria, then you count domain weights, you can classify as SLE patient confidently. But if there are borderline cases, you still use clinical judgment. So disease activity, as earlier mentioned, SLE, TAI, or BILAG, that we have already mentioned. So 2019 Euler ACR tells us only whether it is SLE or not, but activity is measured via this SLE, DAI, 2K, or BILAG 2004. So when we mention SLE, DAI, 2K, if score is greater than 3, then this is active, and if it is less than 4, then this patient is in remission, or LLDAS. And as per BILAG 2004, this is system based, so A or B, that is severe or moderate activity, and similarly C or D, that is mild and inactive respectively. So summary line I can use is 2019 Euler ACR SLE criteria requires ANA positivity first, then you assign weighted points from clinical and immunological domains. A score of greater or equal to 10 with at least one clinical feature classifies the patient as SLE, and the heaviest weights are given to renal, neurological, arthritis, and malar rash features. Another point that we mentioned during discussion was direct combos test in SLE. You see, 2012 SLIC criteria listed positive DCT, that is direct antiglobulin test, as an immunological criteria. Importantly, it counts even if there is no hemolytic anemia. Why? Because a positive DCT shows immune dysregulation with autoantibodies coating RBCs. That is a typical autoimmune feature of SLE. So why is this important? Because autoimmune hemolysis is already a hematological criteria as per the criterion. So to avoid double counting, if a patient has hemolysis plus DCT, SLIC made DCT immunological. So if patient has hemolysis present plus DCT positivity, so this will be only counted as hemolysis, not both. But if there is no hemolysis but still DCT is positive, so it will be counted as an immunological feature. So clinical relevance is some SLE patients show direct DAT positive years before hemolysis develop. So hemolysis will be absent but DAT will be positive. So this will be counted in the immunological criterion. It helps us detect latent autoimmunity. Although it's not specific, it can be seen in other autoimmune diseases, also some infections, lymphomas, but in the right clinical context, it is supportive. So in SLIC criteria, a positive direct Combs test is considered an immunological criterion for SLE even without hemolysis, because it reflects underlying autoantibody mediated immune dysregulation. If hemolysis is present, then you can count this as this hemolysis as a hematological criterion to avoid duplication. So we'll consider this an autoimmune hemolytic anemia. Then you will not classify this separate as this immunological criteria. Thanks.